yesterday I did not finish speaking about a couple of questions that came up, and I wanted to begin with that and then go back here. I'll call it refractive engineering for lack of a better term, but for me it's really reducing the binocular interference or promoting binocularity with our prescriptions rather than just looking for acuity initially. Somebody asked, I think it was Dr. Maslin actually also asked about myopia yesterday, high unilateral myopia. I haven't worked with very many, so I can't give you a lot of stuff, but my thoughts on it, because one of the problems for me these days is I get these ideas on a lot of stuff, and I'm not in clinical practice to do it a lot. But in my years, I saw very few. Again, you may see a lot of high unilateral myopes. You have the problem with acuity. But I would try to cut the minus a little bit if I could, try to get better binocularity in the same way to see if I could do that. But eventually, you're going to have to see if you can pull the minus down a little bit. In my own practice, when I was doing myopia control, I was able to eliminate as much as 3 diopters of myopia and reduce that. Not in amblyopes, but in just other patients. And that's measured myopia, not just, they're blur interpretation myopia. What? Not pseudomyopia. No, these were myopes. These were 6 diopter myopes down to 3. Well, I guess you could be a 6 diopter pseudomyope, for 20 years or 30 years, but I assume they were real myopes. I've also had good success with cylinder as well, but I want to go back to prescribing cylinder actually for this as well. I try to cut cylinder as long as cutting the cylinder does not interfere with binocularity. So everything is about binocularity, not about acuity. And I see cylindrical changes as well, and reductions in cylinder. In my personal experience, the biggest cylinder that I have seen is 1.75 reduction in cylinder. So, congratulations, Beth, on fellowship. So I try to cut prescription as much as possible as long as it does not compromise binocularity in any way. So again, as I had on a slide yesterday, minimum prescription for maximum result or finding to reduce this binocular interference, which is the driving force behind the problem with acuity. And I said something yesterday, and a couple of people asked me, and it was, again, a very big paradigm shift for me. It seems as if, from reading the literature, that the acuity is there. We're not developing the acuity. 20/20 is in there, if we get it, or 20/30 is in there. It's in there, and the 2100 is the suppression of the acuity that's present. That was a huge paradigm shift for me. Is everybody clear about that? Because is that big for people? That was big for me, that it's there. We're just unlocking. Sort of like when, I don't know if it's a good analogy, but it just came into my head. A real shy person that's really beautiful inside, you know what I mean? And somehow that you unlock the key and this person comes out that you never knew was there, type of thing. I think it's sort of like that. Not that it's developed, that it's being actively suppressed. Okay? So let's come back to where we are today. I hope that was helpful. The next stage, I think, is an absolutely critical stage, and that's the MFBF stage, monocular fixation in a binocular field. The analogy they use in the book, so I can speak to that, the first phase, the building confidence, is just you're sending the big brother out of the room. The bully. The bully's sent out of the room, and now you're working with the little brother, and you're asking him to speak. And that's great, and he's getting big and strong, but then the big brother comes back into the room, and he stops speaking again. So now what you're doing is you're asking the little brother to speak while the big brother is standing next to him. Okay? And now speak, and here's your brother. Okay? So, oh, I forgot to put it in again. Jeez. Okay. Okay. So, you want the big brother to speak when there's lots of stuff going on. Okay. Okay, so MFBF techniques allow both eyes to see peripheral objects while only the amblyopic eye sees the central details. Frequently results in additional acuity improvement, and it, again, increases the possibility that gains will be maintained over time. And that's a critical aspect when you think about patching versus this. Patching, frequently, people get reductions in acuity when the patch is removed. This hopefully ensures that that's not going to happen. So what you're doing is, I'll even do this one, this is even better. Okay, you take, and you ask them to, drive their car from point A to point B. If they have red over the non-amblyopic eye, and they suppress the amblyopic eye, they can't see anything, because they're seeing a red print or red lines on a red background. Okay? So the concept is, so it's really, I want to make sure everybody's clear. I know a lot of people understand this, but I want 100% to be clear, is that everything is seen. Your hands are seen, the board is seen, the wall is seen, everything in the room is seen by both eyes except for those two lines. So everything is binocular except for the fine detail. You can also put red filters over things. You can do tracings. You can do dot to dots. You can do heart charts, printed in red. Whatever you want to do so that everything is seen. So again, you're asking the little brother to speak while the big brother is present in the room. Okay? That's clear to everyone? And then you can do all your monocular technique, not your monocular technique, all your eye movement techniques, all your eye-hand coordination techniques, et cetera, et cetera. Okay? Just anything that's going to make it so that you can't see if you're not using both eyes. And there's just tons of things. They make games. Arnie Sherman has, I think Burnell sells it, some playing cards. You can play card games with kids. You can look at stores. There's a company called Red Green Toy Box that has tons of this stuff. Nice games. They sometimes exhibit here at COVD. And they have lots of fun stuff for kids. Is everybody clear about MFBF? Okay. I now am going to tout my instrument because almost every single program on the SVI can be done monocular in the binocular field with perfect cancellation. Okay. And what's nice about it is you can do dynamic things. So you can do tachistoscope, monocular in a binocular field. You can do rotators, targets, on monocular in a binocular field. You can do saccades, monocular in a binocular field, et cetera, et cetera, et cetera. You don't need this. It's just nice. It's motivational. Actually, when I read the neuro research, it made me like the instrument more. And the reason why is because motivation is one of the keys for neurogenesis. Kids like to do this. Forget about even the therapeutic value, just they like it. They attend to it. They're motivated. That creates more neurogenesis. Okay, so, and I want to give a quote, which I like. Dave Damari, past president of COVD, now the dean of the school at Ferris State. It's the best instrument available to successfully treat amblyopia. Oh, and you can also, for those of you that have the charts program, you can also, again, work on the crowding phenomenon, because you can work on letter size and letter spacing independently. So again, big letters far apart, big letters closer and closer together. Go to smaller letters, move them closer together, smaller letters closer together. The other nice thing, by the way, for people who have it, and then I'm going to go on to another slide. I don't want to spend the morning talking about the SVI. Everything is printable, so that all of your heart charts can be printed in monocular, in red, or in binocular, if you have the charts program. Any screen can be printed. So you have an unlimited number of charts, so kids don't memorize the charts. So you can give charts for home with wide spacing. So you can give a heart chart for home, but it has wider spacing, or bigger letters, or smaller letters, or printed in red, or whatever you want to do. Yes. I think yes. Okay, that's about. I've been told yes. Okay, people use it. My problem is, believe it or not, I've never used this clinically. Not once. I was developed. I was really against computers. I'll just take 2 seconds. I was against computers. Rod talked to me for 20 years about. I never went over to his booth. I said, I just don't like that stuff. Give me the, it's from the old school, old school, old school. And then I got ill, and I had a surgery, and I was in the house, and I couldn't drive, I couldn't do anything, and he called me and said, you interested? I said, yeah, just send something. So he sent me a TV, he sent me stuff, and we talked on the phone, we knocked it out in 2 months. We had 100 rewrites in 2 months of the software, and that's how it came about. If I wasn't ill, there would be no SVI. But so I've been told you can print all this out. I've been told you can do all of this. But you have an unlimited number of heart charts, because one of the problems with heart charts is obviously OFN, PV, BCHE, YBAK. I'm obviously, okay. And you don't even try to memorize it. It's in there somewhere. You do it 10,000 times. So you haven't just push a button and you got a new heart chart. Push a button, you got a new heart chart. Push a button, you got a new heart chart with letters and arrows and numbers and all the stuff that's on there. So for those of you that have $300 a month, if you want to, free, I would really recommend the instrument. That's all I'm going to say about it. Now, the last part, which is crucial, is building binocularity. People don't spend enough time on this with their amblyopes. It's especially true for people who just patch, get acuity improvement. But I find even with people who do vision training, they get the acuity up monocularly and they just sort of, I'm pretty much done. No, you're not done. Stereopsis is the glue that's going to keep this. I call, by the way, binocularity glue. Oh, here it is. Sensory fusion and stereopsis maintains the gate from being. It's the glue. Neural glue. Okay. So binocular therapy, eliminate any remaining suppression under binocular conditions, stress anti-suppression aspects, especially central suppression, develop normal sensory motor function, develop and enhance stereopsis. Brock string, vectograms, anaglyphs, aperture rule, mirror stereoscope, lifesaver cards. The SVI fusion program isn't available in America. VTS4 program. Any of your binocular stuff. I'm big on vectograms. I like vectograms much, 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 much better than red-green. We'll talk about that more when I talk about strabismus. They're not the same at all. Okay, everybody understands all the binocular things you can do. This course is not to go over and demonstrate how to use a Brock string and how to demonstrate how to use vectograms and how to use that stuff. You can get that in a lot of different places. You don't need to hear me say it. Okay. I like stereopsis means seeing solidly. It's not just a depth perception. It's a very sensitive probe into binocularity. So I want you to really, that last sentence, think about your stereo test. And when I get less than 20 seconds of arc in a patient, I think there's a problem in binocularity. not optimal binocularity. Oh, here's the quotes I talked about. Stereopsis is the single best indicator of the overall function of both the sensory and motor portions of the visual system. So the big message here I want to give you is when you're giving that stereo test in your office, and if you're doing it or you're having your tech do it, it's not a throwaway test. It's not a test where you don't control lighting well. It's not a test where the kid is, can you see that dot? It's the left one. No, you have to keep it 40 centimeters. I really, really, really want quality findings on my stereo test. And that's my measure if I'm really getting tremendous improvements. The improvements I want in my therapy is my stereo test. But again, it's not we're going to measure depth perception, which is probably said in most offices now. Okay? We're measuring the quality of binocularity. Here's another quote, and the part here that's really amazing to me, and I just want to read the last sentence before we get into strabismus today. Stereopsis also provides for quicker and more accurate cognitive information. So, binocularity isn't just a nice thing to have. I think it's an important thing to have. Okay. Summary of conclusions. Don't forget to treat the whole child or adult. You're treating a person with amblyopia. You also therefore you need to work on learning problems, motor, bilateral integration, visual perception, etc., etc. Don't just work on an amblyopic eyeball that's coming into your office. And people forget. I forget. I mean, how many people, really, how many of you here, an esotrope comes in, an amblyope comes in, and that's what you see? Okay. Classical treatment of amblyopia just treats eyes. Okay. It's not based on neuroscience, the stuff that neuroscience is telling us now. Somebody spoke to me after yesterday and said after the course yesterday, and said, well, I work in an area and a lot of people are skeptical and there's a lot of other optometrists or MDs and I'm afraid to do a different treatment because I don't want to do something different. This therapy that I spoke about has science behind it, has lots of studies behind it. It's patching that doesn't, that shows poor results. Okay. We change brains. We change lives. Okay. Let's talk about a subject I do pretty well with, but I can't say I love when I go out and I see a 50 diopter esotrope sitting in my reception area that I'm ecstatic. I can't wait to get started. It makes me religious. It does. I go out and I see a 50 diopter esotrope and I start praying, I hope they're hyperopic. I hope they're hyperopic. I hope they're hyperopic. I hope they're hyperopic. Please make them a 5 diopter hyperope, please. I see people laughing. It's true, And then you go out. And it's bad enough when they're plus a quarter, but when they're like a diopter myope and they're undercorrected and they really need 2, and the 2 makes it worse, it's like, I must have been bad and I'm being punished. Okay. Babies are born with, we're going to do that true-false again. Babies are born with strabismus. True? False? Don't know? Some babies? Well, there was a very big study done by Nixon and Helveston, two ophthalmologists, I think in Texas, I'm not sure if that's where they're based. Incidence of strabismus in neonates. Over 1,200 consecutive births. Okay. Conclusion of study. Not even one infant displayed typical signs of congenital esotropia. Congenital infantile esotropia is not conatal, meaning happening at birth, but rather develops in the first few weeks or months after birth. Strabismus is a developmental problem. It's a failure of binocularity to develop. It's it's really a learning disability in a sense in the binocular system. Okay. Okay. Learning process, developmental learning. That changed my thinking about strabismus. Okay. Strabismics have problems with eye muscles. There you go. I'm going to have to change my slides. Yes and no. Yes, if they've had surgery. They have problems with eye muscles. It's true. Okay. There's a tremendous paper. It's old now, but it's unbelievable. It's by A.D. Rudiman, M.D. It's a chairman's address on the section of ophthalmology before the AMA. It's an ophthalmologist who stopped doing surgery and started doing what he called foveal coordination exercises. And he increased his success rate from a low of 20% or something like that. I don't remember. You really get the paper. It's available if you just Google Rudiman. And up to like 60% when he stopped doing surgery. He also quotes Javal, if they think about other people. Javal called extraocular surgery the massacre of the eye muscles. Okay. The entire premise on which strabismic surgery is performed is not correct. Eye muscles are normal in almost all strabismics. There are some that have other problems. Less than 5% of strabismics have any primary problem with eye muscles. Okay. Problem is not in the eye muscles. It's in the brain. This is one of my favorite things. This did come from me. Cutting eye muscles to cure a visual problem is like cutting tongue muscles to cure a speech problem. It's not where the problem is. It's not in the tongue. It's not in the eye muscles. Strabismus is a neurological problem. Again, I'm not talking to parents. Now I'm talking to you guys. I'm not going to say your child has a neurological problem because they're thinking brain tumor. But that's where it is. And we have to give new training, build new pathways, neurogenesis, dendrogenesis, to create straight eyes. Early surgery is best for infantile esotropia. The earlier you get it, the better. Okay. There is a study that shows higher rate of gross binocularity with very early surgery. There are also studies that don't show it. However, also, early surgery, higher reoperation rate, and higher incidence of amblyopia as well. So maybe you get better gross binocularity, but you lose some stuff. And again, if surgery was the only way to help these patients, you do it. Optometric, you have a heart valve defect. Therapy is not the answer. Surgery is the answer, and that's what you do. But if there's a better way, okay. Good scientific studies support surgical versus non-surgical treatment. I think that's important, don't you? I mean, what's the big issue when ophthalmologists speak to us? Where's the data? And I think we need data, by the way. People like Sue Cotter and other people that are working on all of this stuff. Get a copy of the Cochrane collaboration. The Cochrane collaboration is amazing on a lot of topics. This is a large group of scientists who do research on all kinds of stuff. The efficacy of insulin, on reducing diabetes, or on this drug for glaucoma, or treating it's not just on strabismus. And one of the things they looked at was interventions for infantile esotropia, published by Elliott and Shafig, part of this Cochrane collaboration. They did a large retrospective study of all published studies on surgery for infantile esotropia, every one. They did this about 5 years ago. Isn't that a pretty picture, by the way, on the top? Okay, conclusion of the study. It has not been possible to resolve the controversies regarding the type of surgery, non-surgical interventions, and optimal timing of either type of intervention. So what they said in the study, basically, is there's no agreement and no study that shows the best time to do the surgery, which muscle to cut, and how much to cut. So does that make you feel comfortable? We really don't know when to do the surgery, Mrs. Smith. And we're not really sure which muscles to cut. And we don't know exactly how much to cut them. But I'd like to cut your child's eye muscles. That's the reality. Yes? No, they didn't look at vision therapy in there for the non-surgical. But what they did say, and is in the literature, is there are children who are strabismic who have spontaneous recovery without surgery. And there's never been a longitudinal study to look at, okay, we do surgery on this group, we don't do surgery on this group, where are they 5 years from now? How many of their successes would have been successes anyway, without the surgery, or how many could have been successful and are now not successful because they did the surgery without even therapy? So they didn't look at therapies. I mean, they also did a study, I think, the Cochrane on, vision therapy, and didn't come up with, there's a very clear idea, good studies. We don't have a lot of studies as well. It's not like we have, these gold standard studies on our treatment. And we need that. But on the other side, they don't have any studies. And they're doing a very invasive procedure with huge risks, which I'm going to talk about. Huge risks. Not small risks, huge risks for a cosmetic procedure. Okay. Was there a question or hand? Yeah. Cochrane. It has an E at the end. I'm sorry. I didn't spell it right. C-O-C-H-R-A-N-E. Cochrane. Thank you. Okay. The size of, this is huge. The size of the strabismic angle should be a strong deciding factor in deciding whether surgery should be part of the treatment. Agreed? 30 diopters, 45 diopters, I think we need surgery as part of the treatment. 50 diopters, 60 diopters, 70 diopters. Yes? No? Really? People see a 70 diopter esotrope and say, I think I can do that without surgery? Do you understand? I think no. This is Carol who I was talking about. This is the largest strabismic I ever treated. She had had 2 prior surgeries. She was more than 65 diopters esotropic. She had 20 diopters, a little greater, of hypertropia. 47 years age. Bottom picture, 10 months of optometric vision therapy. But on the bottom, by the way, she's strabismic on the top, she's strabismic on the bottom. She has anomalous correspondence on the top, she has anomalous correspondence on the bottom. She has no stereo on the top, she has stereopsis on the bottom. Anomalous stereopsis, but stereopsis. No security in space on the top, security in space on the bottom. By the way, this is, I started it, but actually it was finished by Dr. Mary McMains from Houston. Finished it. She used it as her COVD fellowship case when she did it. This isn't one of these before and afters taken the same day, obviously. What the most remarkable thing, and she took the photographs of these photographs from me, is that was the way she came in the first time I saw her. Unhappy, housebound, used to go out at night to go shopping because she couldn't look people in the face. She didn't go to parties. She didn't do this. When her eyes were straight, everything about her changed. But, and I'm going to talk about this with treatment, there was no, by the way, no monocular work. Matter of fact, I think the key to success was there was no monocular work, which I'll talk about. We're going to talk about treating this in a different way. The other thing I want you to get at this moment, does anybody think I could build 65 diopters of divergence ability in a patient? I mean, in normal binocular people, if I get 30 base in, I'm happy. True? I mean, the vectograms, P is only 16 base in. And I'm happy when they can pull the vectograms apart, past P on the vectograms. 65, you'd have to have a vectogram on that wall and a vectogram on that wall, you know what I mean, to get 65 base in. This is a paradigm, for me, was a paradigm-shifting patient. Her vertical fusional ranges were 2/1 on the bottom. She's not pulling her eye down 20. She's not pulling her eyes out 65, like walking around, okay, I'm diverging. She is comfortable on the bottom. She just chose a different strabismic angle. I arranged conditions for her to choose a different angle of strabismus. Your anomalous card point is here. Now her anomalous point is here. No more effort on the bottom than on the top. We did not do any of the Brock string. Can you imagine where the Brock string had to be? If you were using Brock string, the bead was like on this side of her nose. I don't mean out. I mean, it would have to be laying on her nose. Look at her eye. We'll put it on her eyebrow. We'll just tape a bead to your eyebrow, and let's see if we can, separate it from your eyebrow. There was none of that creeping out. She made 2 big jumps. Her hyper disappeared in not 1 week after beginning therapy, but her hyper disappeared from 1 week to the next week. All. And her strabismus decreased from 65 to 40, and then from 40 to 4 in 2 jumps. Now, that took 10 months. It wasn't like first week, second week. But it was like, bang, okay, you convinced me. And I'll talk about how we did that when we talk about that, when we get into the therapy part. Okay. Her vertical, she doesn't have a vertical on the bottom. That's another thing. Alternate cover test doesn't show 65. It shows 4. There's no latent strabismus anymore. I mean, there's a small angle, on the bottom one. But she's not like holding her eyes straight, and really when you do the cover test, you see the strabismus come back. She has a little flick. And I've lost track of Carol, but at least 5 years later, that's exactly the way she looked. And I'll talk about that, okay? So there was no attempt to break the anomalous correspondence. There was no thought to ever try to build fovea-to-fovea correspondence. Not no thought. We offered her the possibility near the end of therapy. She said, I don't want to use fovea-to-fovea. I don't mean she said it verbally. She said it during the procedures. I don't want to use fovea-to-fovea, but I'll take 4 diopters from fovea. That's acceptable to me. I'll stay there. Yeah. Her, yeah. What? It may still be there somewhere. I don't know. Maybe. Yeah. I mean, maybe it's there. Okay. Well, I don't know if it's. I don't know. I guess the pathway's still there, just like a pathway for everything is, I guess, still there. I guess. Oh, no. No, I don't agree with that. No. So I'm not saying the pathway is not there, but this is, I really want to go back to this. This is really important. This is not compensatory in any way, shape, or form. This is a new software program. Okay? Maybe somewhere that other program is there. When she's tired, she's 4. By the way, I'm not saying I don't have patients when they're tired. I also have that type of patient. When they're tired, it's really there, and you unmet. For her, she chose a totally different pathway, a different person. So maybe you were shy when you were 4 years old, and maybe that shyness is somewhere in you, but you don't see it ever. You understand? So maybe it's in there somewhere. I don't know, but I can't find it. I'll take myself for a moment. I'm having some visual problems right at this moment. At this moment, I have some retinal issues. But I was in an automobile accident when I was 19 years old. I wore 16 diopters of vertical prism for 5 years. I had blowout fractures of both orbits, among other things. Okay? 5 years, I go through vision therapy. For the time I was 25 years old till the time I was 69 years old, 4 months ago, before my retinal issues, I measured orthophoria vertically, horizontally also, but vertically, and 0 fixation disparity vertically. The 16 isn't there anymore. 0 prism in my glasses. Maybe it's somewhere in my brain, I have no idea, but it's, okay? No therapy from 25 years old to 69 years old. 0. Totally different software. It wasn't compensatory where when I was tired, something happened to my eye. And I have a physical hyper. I have a non-functional superior rectus in my left eye. And I had orthofixation disparity. It wasn't there anymore. It's just not. So maybe that learning disabled kid, that kid that was in special classes, is somewhere inside me. But he doesn't come out very much, I'll tell you. You know what I mean? When I read, he's not there. When I'm lecturing to you, he's not there. That insecure, I'm not smart, failure in life kid is just not part of me anymore. And the same thing visually. So I'm not saying I never have cases, especially my intermittent exotropes, okay, where when they're very tired, sometimes that eye goes out, although I'm having better success with that too. If we have some time at the end, I'll be happy to talk about a different way of looking at those, because I have way better success treating that in a different way as well. And a couple of really key procedures, which I'll talk about, if you can remind me if we have time at the end. So no, I'm talking about literally different software program totally, not not something masking it, not something that's really there and when they're tired. It's not there anymore. That person doesn't exist anymore. Or if it exists, it's like, I don't know, buried somewhere. It's dead. Okay. Carol gave no effort on the bottom. Zero effort. She's not diverging on the bottom. That's a huge paradigm shift. On the bottom one, she's not diverging to keep fusion. It's not that, it's something different. And I want to talk about that. And I'll show you some more slides of other people as well. Okay. This isn't my patient. This is Pilo's patient. No strabismus surgery, 45 diopter constant resotropia. Bottom photo, age 4, 4 months of wearing binasal occlusion and home VT only. 15 diopter constant right esotropia, and is going to begin vision therapy. I don't know where she is now. This is about a 6-month-old slide. Somebody was speaking to me about home therapy, or they don't have a, I can't remember yesterday. Oh, I know who it was. Okay, Medicare kid. Okay, or Medicaid kid. You know, no therapy. Okay, this is, you know, a $10 treatment. Okay. So I think that's great surgical success if that was surgery. Surgeons would put that in their success column. Parents are happy. Still strabismic at the bottom? Yeah. But let's just say it even ended up like that on the bottom. Not bad. Not bad. Just with binasal occlusion, which I'll talk about. So, a lot. Yeah. I don't remember. I don't know. It's not my case. She sent me the slide and said, look what I did. I just put binasals on, and I don't know what she did at home. But that's without in-office therapy. That I know. If you want to write to me, I'll write to her. Okay. Again, I did this slide yesterday. Critical period. Yes. Okay. But from birth to death. Okay. Sue Barry is the primary example. Everybody knows, if you have not read the book, Fixing My Gaze, buy the book. If you don't like the book, Fixing My Gaze, I will refund your money. Send it to me. That's how sure I am that you will like the book. Not only is it a great story about Sue Barry, you will feel better about being an optometrist after reading the book. It's a must-read for, in my opinion, every optometrist. Fixing My Gaze by Sue Barry. So here's a woman. How many people don't know the story of Sue Barry? Or does everybody know the story of Sue Barry? You don't know? Okay. 45 years old, or 47 years old, I don't remember exactly, teaching neurobiology and neuroplasticity. And yet thinking, I can't do anything, and everybody telling her she can't do anything. She gets referred to an optometrist, and I think this is the beautiful part. And I want to say this, I'm going to say this in a way, and then I'm going to explain it. She was sent to a nobody, and I don't mean it, but she wasn't sent to a very important person. She wasn't sent to this famous person. She didn't go to this person who lectures around. A person who does quality vision therapy in a small town in Massachusetts, who wants no publicity, who doesn't have a big flashy office, who's a very simple person, just an incredibly competent, honest, competent. And what she says to Sue Barry is what I said to you yesterday. I can't promise you anything. I don't know what's going to happen, but I'll give it my best shot. Well, Sue Barry is now binocular. She has stereopsis. Nobody believes it. Oliver Sacks comes and brings an ophthalmologist with him, and two Nobel Prize winners write on the jacket of her book. David Ubel says, we were incomplete. There's an NPR, if you want to look up, listen to his interview. We didn't look far enough. All we said is, there's this critical period for this. We didn't say you couldn't fix it. Okay? What's interesting now, though, because I became very good friends with Sue, and we happened to be speaking on a program where we spent a week of vacation together. She sees ophthalmologists periodically when she speaks and other things like that. They tell her she wasn't really strabismic. And what she says back is, so this, a very famous, her surgeon was a very famous surgeon at that time. So they did 2 strabismus surgeries, or 3, I think. I don't remember which one it was. And I wasn't strabismic. That's the first one. But the best one is, about a year ago, she goes out to one of the big guys in Washington, D.C. area. I think it's Bethesda Naval Hospital. And she tells him the story, and he says, the surgery finally kicked in. Couldn't have been the therapy. Surgery finally kicked in. So you talk about that Einstellung, or whatever the other thing I showed you yesterday. Okay. So let's talk about, maybe I am going to talk about exotropia. It is left them in my slides. What ophthalmology has available to them is occlusion, full optical prescription, and surgery. What we have, lenses, non or partial occlusion, and VT. I want to talk about strabismus surgery first. Nice photo? Lovely? That's what it looks like. Okay. Potential problems. I want the reality of this to sink in. These aren't made-up photos. Okay? Disadvantage number 1, potential secondary surgical risks. There are numbers of articles that discuss about the percentage of slipped muscles or lost muscles, perforations of globe, retinal detachments, infections. And they have stats on all of these things. Now again, they're low. It's 1%. It's 2%. It's 0.5%. It's 3.5%. And if there were no better way, great. But there's a better way. And again, just look up, if people want it, I'll get the studies to them. I don't know if I have quotes on all of them. And a lot of them are in the book. Over or under correction. They have stats on this. Not only do they have stats on this, there are stats of phorias to tropias. They have stats because they operate on high phorias. What percentage of high esophorias go to the esotropias or exotropias? 7% of this, 5% of this, 8% of this, 25% of this. Like, yeah, that's just the way it is. And again, if there wasn't a better way, great, you take the chance. But there's a much better way. Overcorrection are part of strabismus surgery that will... Overcorrections are a part of strabismus surgery that will always occur because it is not an exact science. I mean, they publish this stuff. Nevertheless, it is important to perform surgery after obtaining accurate reproductive measurements in the angle of deviation. I want to ask people a question, too. A lot of your strabismics, right, are like 20 at near and 40 at far, or 40 at near and 20 at far and 40 at near, or whatever. Which one do you pick for your surgery? You cut for 20, you cut for 40. Well, you split the difference. Or you cut the muscles for, these are your far muscles, these are your near muscles. Okay. Okay, so very important to attain accurate reproducible measurements. However, this is not always possible in young patients. And the inability to obtain accurate preoperative measurements in all fields of gaze probably accounts for less than optimal results in this age group. Okay. Because most of these children have at least intermittent binocularity, it may be prudent to delay surgery until you are confident in your measurements. How many ophthalmologists listen to this? This is what I love about this book, because all this stuff is in the book. Yeah. Well, for me, well, what I understand strabismus to be? So that, I think it's a failure of developing binocularity. I think it's a learning problem. I think it's a neurological problem. I mean, the eyes are, it's so illogical to me. The eyes are connected nowhere. If there was a ligament between both eyeballs, you know, connecting both medial recti, then shorten it. The eyes are connected nowhere but in the brain. So it is a neurological, neuromuscular problem. Why are we calling it? I don't know what I should call it. Okay, muscle surgery. Yeah, okay, but good. Yeah, muscle surgery. Or even better, using Javals. I think Javals. The massacre of the extraocular muscles. Quote. No, I think it's great. I think it's great. I mean, it is a really inexact science. And what I want parents to have, and that's what this book is all about, is information on both, good information with scientific studies on both sides, and then choose. I'm not going to choose for the parent. They want to go and take a chance and roll the dice that their kid is going to have straight eyes after one surgery or two surgeries. Great. Not my choice. What pisses me off, on tape, pisses me off, okay, and makes me angry, is that they're not informed about the risks, that there is another option. You know, chemotherapy, no chemo. This is what's going to happen if you do chemo. This is what your chances if you don't do chemo. Not your only option is chemo, or your only option is not chemo, or whatever. It's both. So I want them to understand surgery. So I agree with you. Yeah, it's not muscles. You know, it's muscle surgery. If there's a well, yes and no. The question is, if there's a restriction in the muscle, would you do surgery? I have had lots, only after the patient proves to me I can't get another pathway to get into that muscle. No, I have had physical. Yeah, no. I mean, I've had cases where there was a physical restriction, and then you get the eye to move in therapy. But occasionally, yes. Or you give up that field of gaze. So, I mean, I can't move my eyes. I'm strabismic in upper left gaze because I can't get my left eye up there. But straight ahead, down, right, left, good stereo, good fusional ranges. And I have one side of my face, one orbit, is physically higher than the other. And I fuse like this. I mean, look at my cover test. I have no movement. I mean, there's just no movement. I mean, you can look at me and say, oh, yeah, you got a left hyper. I don't have a left hyper. Physiologically, anatomically, I have a left hyper. Physically, no. You know, and it's easier to see that the eyes are much more level when I lift the lid. Okay, so there's a lot of physical things. But I'm fine. So I have referred maybe, in 25 years, maybe 5 people for surgery. Pilar, 0 in 20 years. 0. Zero. She's had all kinds of cases. She's had Dwayne, she's had Brown, she's had this and that. Okay. Number 2, neural and spatial adaptations. EF and AC may be stronger after the surgery. Diplopia can be much worse after the surgery. You know, they were diplopia out here. Now they have 2 images that are almost superimposed, but not quite superimposed. By the way, that's really the way it looks. I had diplopia for 5 years. It's bad. Okay. Risk that the patient could possibly be worse before the surgery. People look cosmetically worse. Surgery sometimes increases angles. And, I don't know if it's in another slide or this one, this is the real gift. No hyper, now you have a hyper. No cyclo, the big gift. No cyclo, after cyclo. And now we have to try to do vision therapy on a patient with cyclo. That's a hard job. Give me a 90 diopter isotrope versus somebody with 10 degrees of cyclo and any size angle. They induce it. They make the patient, they make our job harder. I'm getting back to that. So I would prefer and try everything before I try surgery. But I preferred some. Okay. Emotional trauma to the child. Long-term emotional trauma. Separation, pain, fear, etc. It's in there. Again, what I took, Cochrane has an E. And it's not Cochrane, it's Cochrane. No good scientific research on what age it's best to do the surgery, how much to cut, or even which muscles to cut. No agreement. This is the huge one. Big, big, big. I think this is the primary reason to delay strabismus surgery. Study, yeah. Journal of Pediatrics, long-term differences in language and cognitive function after childhood exposure to anesthesia. Now, I guess if they're going to do the surgery without anesthesia, this is not a disadvantage. Okay, but assuming they're going to put the child under anesthesia, which I think is a high likelihood, they first did a study on 2 anesthesias, and then they did a study on just 1 exposure to anesthesia before, I believe, age 3. Let me just see. Age 3. Neuropsychological assessment at age 10 indicates that children who had been exposed even only once to anesthesia before age 3 showed significant deficits in receptive language, expressive language, as well as cognitive deficits in abstract reasoning as compared to children who were not exposed to anesthesia before age 3. Wow. Okay. You got a kid? You want to take the chance that when this kid is 10, he's going to have more problems in cognitive reasoning, receptive language, expressive language, cognitive reasoning, abstract reasoning as compared to children? Or would you rather wait until after age 3? By the way, it could be age 4 or 5. That study has not been done. It's also possible anesthesia before age 5 would cause the same types of deficits. I don't know. But for sure, before age 3. And the other side of this, there's no data to show that surgery is more successful at age 1 year than at age 2 years. Or 2 years against 4 years, or 4 years against 6 years. No good data. So what's the rush? Yeah. No, I have not. The question was, have I ever read a consent form? But I'm sure the consent form is like for refractive surgery as well. You know, if you could commit suicide after, it's not my fault. You know what I mean? It's, I'm sure it's highly protective, and I imagine it mentions more than one surgery, et cetera, et cetera, et cetera. I don't know for sure, but I'm sure they CYA. Oh, they strung on them terribly. Your child's going to be blind when they get older if we don't do something. Like the strabismus surgery is going to cure the amblyopia. I mean, I have a surgeon in San Diego that tells 5 diopter hyperopes, we'll see after the surgery whether he'll still need the glasses or not. What percentage do you think don't need the glasses after surgery? 0. They all need the +5, and he does it anyway. So I'm not saying, again, that we have the best, okay. This, by the way, here's the conclusion. If the surgery is needed, then they should not delay and should proceed with the surgery and anesthesia. However, if it is determined that the procedure is completely elective and there are no risks for delay, postponing the procedure could be a reasonable choice. I would say should be a reasonable choice rather than could, but they said could. Journal of Pediatrics. You think that's changed any surgeon? Not in my town, anyway. They're still doing surgery on 1-year-old kids. Without knowing which muscle to cut, how much to cut, exactly what age to do the surgery, et cetera, et cetera. It's bad. Oh, I must have taken it out of this one, but I had a listing, if somebody wants it, of which doctors. 4 surgeries, 6 surgeries, 8 surgeries. Again, the one is, the record is 12 that I've heard of, 12 surgeries from a doctor in Texas. I just want to give you a few quotes from strabismus surgeons. This is the one I was talking about from Rudiman, who was the chairman's address, the section of ophthalmology in 1956, a long time ago. Okay. Those among us who have been anatomically inclined have put the entire emphasis on the extraocular muscles, getting back to your comment. Muscles, in my experience, are merely a means to an end. Proper emphasis should be placed where it belongs. First and foremost comes the brain mechanism. He was never heard from again, by the way. He gave this chairman's address, like disappeared. Okay. This is all from this paper. The fact of the matter is that seeing is a learned process. No one is born knowing how to see. The anatomical changes that we find in the eye muscles are minimal, and only in rare instances are they of any importance in the total picture. Okay. Most of these patients have learned to coordinate their eyes incorrectly, and unless the correct method is taught to them, one cannot affect the cure. This is an ophthalmologist speaking. Now, I don't think these are surprising quotes to anybody here. It's just surprising the source of the quotes. Yes, if you look in that paper, you'll find all of these quotes. Okay. Binocularity remains an elusive target and a rare outcome of the treatment of infantile esotropia. Not treatment of treatment. Okay, there's a couple of typos in here, but everybody gets the idea. Binocularity remains an elusive target. Insofar as a cure of strabismus is measured in terms of the restoration of binocular vision, operation cannot by itself affect the cure. It is merely a mechanical expedient to orient the eyes. Duke Elder, ophthalmologist to the Queen. Okay. Okay. So getting back to your question, Tuvia, if surgery is needed, this is what I would consider. Only after you can't do anything with your vision therapy. you want to refer to a good surgeon. There are good surgeons and there are not good surgeons. I have 2 pediatric surgeons in town. One has good hands. One, I wouldn't let cut, a brisket for me. Okay, and by the way, even the other surgeons in town think he has not good skill. He's just not skillful. I mean, my mother would have made a great surgeon. She was a great seamstress. If she would have gone to medical school, she would have been like world-renowned. Some of them are just not. They're just not good with their hands. Okay, that doesn't seem to stop them. A surgeon who works well, I'll put well in quotes, hard to find them, but you can find them. For those of you that don't know, by the way, Dr. Nancy Torgerson from Washington State is now in co-practice with an ophthalmologist in one of her clinics. He is tremendously supportive of the benefits of optometric vision therapy in co-managing strabismics. He's still slow to come around speaking to Nancy about understanding that maybe strabismus surgery isn't needed at all, but he really is more and more and more coming around to seeing the benefits of the work we do, and hopefully there'll be more of that. Okay. A surgeon who appreciates the value of pre- and post-surgical VT, and that's the surgeon she works with. He appreciates that. Okay. What are we going to get for our thing? So they're going to get better measurements. We can develop sensory fusion even if it's at the angle of strabismus, so that there's glue in the system. I want to talk about that. Motor fusion is not what keeps our eyes together. Motor fusion is just the muscles pointing in the same place. What keeps our eyes together is sensory fusion. If not, everybody in this room with aphoria would have atropia. You understand? You have motor deviations. Everybody with aphoria, which is pretty much everybody in the room, even a 2-diopter aphoria, let alone a 10-diopter or a 15-diopter. But if you didn't have sensory fusion, a 1-diopter aphoria would be atropia. There wouldn't be phorias. Either you'd be ortho or you'd be strabismic. The glue that keeps our eyes together is sensory fusion. And if we can build sensory fusion, well, first of all, if we can build sensory fusion, we can do what we did with Carol, but assuming we're not successful, two of you, then when they straighten the eyes mechanically, motorically, there's glue. The problem with surgery is there's no glue, they straighten it mechanically, and the eye goes back in, or it goes up, or it goes out, or it turns, or it does this, or it does that, because there's no reason for the eyes to stay together. It is a sensory problem. It's not a motor problem. Oh, wow, I don't think I had said it quite in that way before. Strabismus is a sensory problem, not a motor problem. The motor problem is a symptom of the sensory problem. I like that. I don't think I ever said that. We have to build glue in the system. And we can do that with vision therapy, even if we don't get the eye straight. And then if you need to send for surgery, you don't have the great success. And again, I had to refer for surgery sometimes, but surgery is, I'll show you some more slides later, but you can do a lot without surgery in most patients. Not all, but most. The vast majority, yeah. Oh, yeah, I'm going to talk about that. Yeah, I'll talk about that. I'm going to speak about that specifically. I know exactly what you're saying. You can be peripherally binocular and centrally strabismic. And I'll talk about that specifically. That's a hard concept. It's a hard concept, but it's true. And I'll talk about that. Okay? What? Carol? Oh, we'll talk about that. Okay? Very specifically. When we talk about a specific test. Decrease symptoms. If they're spatially insecure, what Gary Edding talked about, difficulty driving, difficulty riding a bicycle, lose their place when they read, have learning problems in school, we can help that, even if they're not cured, even if their strabismus is not cured. And we can possibly avoid the need for surgery. And anytime you can avoid the need for surgery, you're helping a patient a lot, because there are risks with any surgical procedure, and especially with young children with anesthesia. I know I'm speaking to the choir. I'm not trying to convince you, and for some of you this may be, I know this, I know this, I know this, I know this. But I want to give you ammunition, and I want to make you feel strong when you're speaking to parents about this stuff. Okay? So I'm not speaking to people who have been doing this for 35 years here. I'm speaking to the people who haven't done any yet, or are in their first or second year of practice. Okay. Why do it after? Avoid adhesions. Reestablish neuromuscular cells. Reestablish or embed fusion. Reduce the need for additional surgeries. The average is 2.4 surgeries. Now, obviously, there's no 0.4, but 2.4 surgeries per patient with strabismus. So some patients get away with 1, other patients are 3 or 4, and they end up with 2.4. Okay, and improve the patient's overall quality of life and visual performance. So again, there's a child with strabismus. It's not just a strabismus. Okay. One of my favorite quotes, insanity is doing the same thing over and over again and expecting different results. Let's cut eye muscles, let's cut eye muscles, let's cut eye muscles, let's cut eye muscles, and they're still not any better at it than they were 50 years ago or 100 years ago. It's hit and miss with torsional problems, et cetera, et cetera. Okay, I need to talk about evaluation in this course. It's something I would just like to, for some of you, by the way, I was going to say this privately, but I'll say it publicly. For some of you who have a lot of experience, and there's a few people in this room with a lot of experience, probably in 2 hours I could have done the 2 days, because I don't need to talk about evaluation, I don't need to talk about this, I don't need to talk about that. But for all of you, I need to talk about evaluation, because it's part of this is preparing for the fellowship as well. So we talked about this yesterday. We're going to go through this part very, 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 very quickly, because the beginning part is exactly the same for this as it was for amblyopia. Good case history, that long case history form. Send your $175 into COVD. You'll get the forms as well as, not forms, excuse me, the questionnaires with them for patients with learning problems, for infants, et cetera, et cetera, et cetera. Okay. I want to talk about this, though, which is important. I found this fairly recently, and I like it a lot. Goals. What do the people want? And it's smart goals and specific. So what are the specific goals of the patient? I spoke about this a little bit yesterday, but it's important. What do most strabismic patients want, or parents of strabismic kids want? Cosmetically straight eyes. I have yet to have a patient say, my goal is to eliminate the anomalous correspondence. I want fovea to fovea correspondence, or I'm sorry, I don't want to do anything. So they want straighter eyes. I can give them straighter eyes. They may or may not be fovea to fovea at the end, like Carol was not, or they may be fovea to fovea. Everybody understand? They want straighter eyes. That's what they're going to. So if we can do what I call non-surgical surgery, We'll get the eyes cosmetically straighter, easier, no risk of diplopia, et cetera, et cetera. That's pretty good when I take a 50 diopter esotrope and make them into 10 diopter esotrope. Or if I can get them fovea to fovea, great. If not, I'm happy with 10. Okay? Even though it's a failure on Flom's criterion. Measurable results. You know, it was 50, now it's 10. It's 60, now it's 40. It's 65, now it's 4. Attainable results. I had one patient, a woman. She was 27 years old. She was the head of a corporation. Huge angle esotrope. She sat down in my chair. I talked to her about stuff. She said, if you can't give me, her words, fovea to fovea correspondence, I don't want to do therapy. That's why I'm not doing surgery. I said, well, how about if I just make it cosmetically better? She said, I make more money than you. I got a dynamite fiance. He's drop dead gorgeous. I want functional binocularity. Her words. It was like, I don't know. And we were successful. But I didn't promise anything. The interesting part, just to jump ahead because I love stories. So now it's 10 years later, 15 years later. I'm in New Zealand. I'm rafting down a river. Smart me. And, you know, I have one knee in the bottom of the thing instead of sitting on the edge. We go over a big fall. My knee hits a rock. Okay. I'm going home in a wheelchair. They wheel me up to the gate, and they said, somebody come up from the stewardess will come up to meet you here. And the person behind me says, I'll wheel Dr. Sennett down to the plane. It was her. Married, 2 kids, straight eyes. It was a nice story. Her name was Pam. Okay, so attainable goals. But again, realistic and attainable, but I don't know. I mean, Carol, again. You think I promised Carol? She's that huge angle. We're going to make your eyes straight, cosmetically better. Best effort and honesty. That's what we owe patients. And I was like, I don't know. Let's give it you want to give it a shot? You don't want surgery? I'll give it my best. And then time bound. About how long is it going to take? I tell strabismics a year to 2 years. Most of them. Constant strabismics. Frequently I'm completed before then, but I like to give myself plenty of time. I'm a hero when I complete in 7 months, and I told them a year or 2 years. I'm not a hero when I tell them 6 months of therapy, and now I say, it's going to be another 6 months. And I'm going to have to pay for 6 more months versus the opposite. So I always give high estimates. Okay. Key findings, observation. Look at physical appearance, anatomical factors. Okay. Ptosis. I mean, part of this. Look at the corneal. Can you see the corneal reflexes on this guy? They're almost equal. That little baby's binocular. The girl on the top was binocular. It's cosmetic. It's facial. You don't understand? It's anatomical. If they were strabismic and you got them straight, they still don't look straight. And you need to take that into account. I can't make you look straight. My optometrist. Okay? So look at the face. Okay. Look at head position for tilts, turns, warps. Look at the pupils. Look at the body. Are they strabismic just in their eyeballs? Or their brain? Okay. Everybody understand? Or is their whole body strabismic? Sometimes yes, sometimes no. People say, when I was just starting in optometry, must have heard 100 times, A strabismic is strabismic in their whole body. I don't always see that. Okay. I've had strabismic gymnasts. Okay. They're doing backflips off a beam, and I'm going to do angels in the snow with them? I don't think so. You understand? It ain't going to straighten their eyes. Others, you work on the body, you get the eyes look straighter. And you work on bilateral integration. So I'm not saying that first one, the gymnast, it wasn't in the body, but if it's in there, I don't know where it is. You know, and I don't know if I can help it. Yeah. Well, the way I think about it, well, two things. Number one, I'm thinking, is working on motor, bilateral integration, all of those things, going to have an impact? That's my first thought. You know, or I'm not going to spend a lot of time on that because I don't think it's going to have a big impact. Secondly, yeah, the second one, the gymnast, very embedded. Very embedded. Okay. I like them. I like disorganized people. I like clumsy strabismics. No, really. I mean, you know what I mean? You just got to get them organized. The other people, much more. Same thing with that. You know, you have successful people with problems. Why should I cure the problem? I'm successful. Okay, so just look at all that stuff. Okay, so look at cosmetic things, because if you have a big epicanthus, let's say, well, first of all, it could be pseudostrabismus, but secondly, if it's not, you may still have a problem where the eyes don't look straight. So one of the things I said yesterday, practice manage-wise, and I want to say again today, is prepare people for stuff. You know, the eyes are not going to look cosmetic. I can get them straighter, but they may not look cosmetically straight because of this physical problem. You know, you're Asian, you're still going to be, you know, kid's still going to be, or the child's Asian, they're still going to be Asian after the therapy. You know, big epicanthal folds. Okay? So, and then is it reflected in the whole body? Okay. We're just going to repeat these slides again, just as a reminder. Quick. We're going to do visual acuity like we talked about yesterday. Okay. Everybody happy with doing this tachistoscopically? Good. Okay. Fixation status. They have eccentric fixation. They don't have eccentric fixation, et cetera, et cetera, et cetera. Just as a reminder that, you know, you don't just look at the strabismus, you have to look at other stuff. We talked about all this yesterday. Refraction, same stuff, same way to do refraction. Okay. I do want to talk about this just a little bit. So all that other stuff was the same from yesterday, yeah. How do I do cover test and how do I compare it? They're different tests. I usually on my strabismic patients just do cover test in free space. I may also, sometimes I neutralize with prisms. Most of the time I neutralize with prisms if I can. It's the easiest way. But I only neutralize with prisms so that I can measure or have an assessment of, am I reducing the strabismic angle? I don't measure the way I measured in optometry school, so that I had this exact number, you know, in 20 minutes to decide whether it's 41 or 42 diopters of ESO. Like that would be important. And I do a cover test for another reason, which I'll talk about. I'm keeping not secret, but it gets back to a question from before. I want to speak about some stuff with the cover test specifically, that it gives me a great idea of prognosis, but not because of the magnitude of the angle. So I want to make that clear. I do my cover test not to decide whether they need surgery or don't need surgery. I do it as a baseline number so I can see, okay, whatever therapeutic, whatever I'm doing therapeutically, is it reducing the angle? Is it not reducing the angle? I see no difference in prognosis, zero zilch, between a 20 diopter esotropia and a 60 diopter esotropia. In the way I'm going to talk about treating esotropia. Not better prognosis for the 20 than the 60. That was a paradigm shift for me. That didn't come from textbooks, came from patients who responded in ways I didn't expect them to respond. That I didn't think it was possible for them to respond in that way. Okay. So you can do a Hirschberg. Everybody, I think, understands Hirschberg test. Yes, no? By the way, this is good for therapists. Just look at the corneal reflexes. There's something I taught my therapists as well. The eye's going in, the reflex moves out, et cetera, et cetera. To be able to look when people are straight and people are not straight. On my infants, this is an important test. On my adults, where I can get a good cover test, not. So that the numbers on the right-hand side, by the way, are degrees, not prism diopters. So double it, more or less, 1.876, is that right? Does anybody remember diopters to? No, not that, but I mean 1 degree is, I think, 1.76 prism diopters. Okay, something like, but 2 to 1 is a good enough one. So the first one is about a 30 diopter esotrope. The second one's about a 60 diopter esotrope. The bottom one's a 90 diopter esotrope. Okay, so right at the edge of the pupil. And I'll draw a picture for myself, because when I'm working with infants and very young children, and I'll speak about that a little bit later, that's my best assessment of what's happening for the kids, that every time you put up the cover paddle, they're looking at the cover paddle, or they're looking at everybody understands the kids who eat, they start chewing on the cover paddle. So sometimes all I can get is Hirschberg. And I use that as my assessment. Is my therapeutic intervention helping to reduce the angle? The corneal reflex was at the edge of the pupil. Now it's halfway in between the pupil and the center of the pupil, etc. Okay? So I don't think you necessarily on these patients have to do Hirschberg, but you can see where it is, and you can get some ideas of the size of the strabismic angle. All these people are binocular. They don't all look binocular, but they're binocular. I shouldn't say they're binocular. They're orthophoric in here. I don't know if they have binocularity or not. Okay. But they don't look straight. But look at the corneal reflexes. They're all straight. So it's important also for reassuring parents as well, because the baby in the upper left-hand corner doesn't look cosmetically straight, but there's no therapy needed. Okay? Can you see the corneal reflexes from where you are? Okay. So it's a nice way of assessing, is the kid binocular, is the kid not binocular? Okay. And you can see the difference in the corneal reflexes here. One is in the center of the pupil, one is displaced to the left or to the right. Okay? The Krimsky test is just prism neutralization of the, again, I apologize to the people who know all this stuff or teach this stuff, but I need to talk about it. So you just put up a prism in front of one eye till both corneal reflexes are in the same place with both eyes. to get an idea of the size of the strabismic angle. Okay. Are people okay that I'm going through these fairly quickly? Okay. Because that's what I'm teaching you can be found in textbooks better than that. Unilateral cover test. Again, I like, as I spoke about yesterday, translucent occluders. I like them a lot. I can see what the eye is doing. I can see how quickly also it goes out. Okay. Okay. Neutralizing with prisms. Oh, I want to talk about something now. Big, big, big. And it gets to your question, Divya. Okay, I have an esotrope now. Comes in. Unilateral cover test, 20 diopters of esotropia. Okay, cosmetically pretty good. Okay, I do an alternate cover test. They have 45 diopters of ESO. You see that a lot? Yes? What's the difference? Why are they 45 on an alternate cover test and 20 on a unilateral cover test? Peripheral fusion. They have binocularity. It could be anomalous. They're the same as you. Why are you now on a unilateral test ortho, but on an alternate cover test 10 ESO? Fusion. It's the difference between a unilateral cover test and an alternate cover test. So what that patient is telling you is I have peripheral fusion. That's reducing my angle from 45 to 20. I can't get to ortho. I'm not straight. But I'm like partially compensated, if you will. Like your foria is compensated through sensory fusion. So they have sensory fusion, which is straightening their eyes. Great prognosis. And if they have anomalous correspondence, I'm even happier. Anomalous correspondence, sounds weird, improves my prognosis. But not for fovea to fovea. For cosmetic improvement. And I'll talk about that later. I'm sorry, I can't hear you too well, Beth. I have them hold the target sometimes. Sometimes I use the Harry Wax method. I take a sticker and I put it right on my nose. So I have, absolutely. And sometimes it's so obvious, you don't have to measure it. They look cosmetically pretty good, and you do this alternate cover test, and it's huge. With a hyper. And you look at them, they got no hyper. You do an alternate cover test, and there's the hyper. Sensory fusion. And by the way, that's Carol. She's using anomalous sensory fusion, and her eyes are straight with no effort. She just chose a different anomalous angle. Before, her anomalous point was up here. Now her anomalous point is, almost at the fovea. That's it. Okay? So, I like to neutralize it if I can. I like to neutralize it near and at far if I can. Sometimes I only get near. Sometimes I get near and far. Sometimes I get, I have the same problems that everybody else has. Sometimes it's like I get these incredible measurements, and sometimes they're estimates, and sometimes they're only at one distance, especially in your young patients. I'm not speaking about a 16-year-old comes in and she's sharp and she's great and she's cooperative, and sometimes it's tough. And they're estimates, and they're just Hirschberg, or they're Hirschberg-Krimsky. And they're, like I say, they're just at near. I can't get FAR findings very well. Okay, I don't have any magic over anybody else here. I mean, I've had more experience, so maybe I could do better than somebody who, has just seen 3 infants in their life. But it's tough sometimes. That's all I can say. It's not easy. And by the way, that's important to remember also for the young people here. When I was sitting where some of you were sitting, it was like, I always assumed that the person here was like, they could do it. I fumble, I guess, I have great results, I have nothing results. I once did 3 one-hour exams on a kid. After the first 2, the only finding I had was eye color. I swear. I couldn't do cover test, I couldn't do a retinoscopy, I couldn't do her. This kid wouldn't let me near them at all. That happens. Okay, coming back here. Direction of the deviation, magnitude of the deviation, influence of accommodation. I measure with low accommodative targets and high accommodative targets. Especially in your patients where the mother says the eye turns in and you say, and you do your exam, I never saw the eye turning in. Try real small targets. Look hard. But the big thing for me, again, is not the size of the angle that I measure, but the presence or absence of peripheral fusion. So I would rather have, again, this huge alternate cover test than a smaller, cosmetically better, but it's 20 and 20. I'd rather have 30 and 60 or 50 and 90 just to show me they have peripheral fusion. They probably don't. I don't know for sure now at this moment, but I'm less secure. But 20 and 45, I know they do. Well, I'll talk about some other things in a moment. I'm going to do some other tests. But just alone on cover test, I know. Because if you have, on a unilateral cover test, a smaller deviation than on an alternating cover test. By the way, even on non-strabismics. Cover test, unilateral, ortho. Alternate cover test, teniso. Yes, fusion. Okay, so anytime there's a difference, and I'm not talking about a difference of 1 diopter or 2 diopters, I don't, sometimes it's imprecise, but you see 20 and 45, clear they have peripheral fusion, or even 20 and 30. Okay, Bruckner test I spoke about yesterday, 4-prism diopter base out test. I can't do this test. I need a 6 diopter to do the 4-prism diopter base out test. I can't see the movement with a 4. Is anybody good here with a 4? I don't know who invented this test, but you can do a 4? Oh, you passed. I'm sorry, this is my mentee. I was her mentor for the fellowship, so congratulations, congratulations. I take that job really seriously. Okay, so I'm not going to discuss this test now, too, because there's just an article that came out 2 months ago or 3 months ago that said it may not even be a valid test. And called it into question. So reevaluation, if you want to look at that article that calls it into question, reevaluation of the 4-prism diopter base out test by France. Well, not a few months ago, excuse me, came out in 92. October. Yeah, came out in October. 90. Sorry, just one more airplane, he said, like the October. I had to do this chapter that I promised to do for this rehab book. And I promised it in June, and I got it in December, which I thought was pretty good. Problem was, it was 5 years. 5 years later. But it was only 5 months, and it was the worst experience of my life. It was called the effing book chapter. It came out well, I have to say, but it was, I don't like to write, I found out. Okay, so we're not going to discuss the 4-prism diopter test. It's supposedly a test for microstrabismus. Okay, and so that's all I want to say about it for here. I do want to measure suppression, worth 4 dots, polar mirror test, as I discussed before. You want to do this in positions of gaze in different distances. Are they suppressing? How deep is the suppression? Do they have diplopia? Lighted conditions, dark conditions, etc. Stereo, is there stereo? Now, I do want to talk about stereo for 2 reasons here. Number 1 is if they get Randot stereo, you can make a strong assumption. I would have said before that Special Olympics event, 100% a strong assumption there's no microstrabismus. Because at least theoretically you need fovea to fovea correspondence to do Randot stereograms. Even 600. Even 600 or 2,000, I don't know what it is. But yes, you need fovea to fovea. Except to have those 2 anomalous cases. Okay? So you can have, again, 100 degrees of stereo on lateral disparity targets like the fly or the animals or whatever, but not be able to do 600 on Randot if you have a microstrabismus, at least theoretically. Okay. But if they have any stereo at all on the fly, even if it's anomalous, I keep going back to that because it's important. They have stereo, even if I see the eye turn, but they're grabbing the wings of the fly in front. That's a real positive sign for me. I'm going to speak about it. If your goal is cosmetic improvement, if your goal is to satisfy the parents, I want to talk about something, and I have to find this study. Linda sent it to me, actually. So, an ophthalmological study done, I think, within the last, I think it was done within the last year or 2, but I'm not sure, but important. Of patients who did not have diplopia before the surgery, but had intractable diplopia after the surgery. 50% were happy they did the surgery because they looked cosmetically better. Even though they had went from no diplopia to intractable diplopia. Write to me, I'll find the study. It'll prompt me. If somebody wants that study, write to me so I can remember, because I want to find it. But, because it's somewhere on this computer. Okay, but here's what that told me. If we can make patients cosmetically better, they're happy patients. They don't have to meet Flom's criteria. Again, I never had a patient come in to me that said, I want to meet Flom's criterion, or I'm not going to be happy. Carol is a failure on Flom's criterion. She has no binocularity, true binocular, fovea to fovea binocularity. I don't consider Carol a failure, and she was ecstatic. So why I bring that up is I'm going to argue here for making people cosmetically straight and then going for fovea to fovea, rather than going fovea to fovea, then trying to make them cosmetically straight. They're anomalous, I'm going to leave them anomalous. And then ask them. When I say ask them, ask their neurology. You want to be fovea to fovea or not? I'll give you the choice. They choose no and they want to end up at 4. I don't care. I really don't care. If they want to choose fovea, I'm really happy. But I'm not unhappy if they don't. So I don't care if they get anomalous fusion or not. I also do something in answer to your question. I don't know if I have it here or not. No. I put them on vectograms. And at very, very close distance, their nose is sitting on the vectogram, literally on the vectogram, so I get real good periphery. Actually, I'll spend a moment before we take the first break. I want to talk about this. This is the way I set it up, okay? And it's a good prognostic indicator as well. So now I have two vectograms together. I have the Brinell number 9 vectogram in the middle, which is the acuity suppression vectogram. Does everybody know it? It's two rings and 7 lines of letters, I think. Everybody understand which one that is? Okay. And then around that, in the second track, excuse me, that's in the second track. In front of it is the Coit's vectogram. There are 3. The acuity suppression's 1. It's a single, non-variable one. And in front of it, so there's 2 in front and 1 sitting in the back. So they say a rope, and inside that rope are 2 rings and a whole bunch of letters in the middle. Okay? Can people visualize the setup? I don't like it projected as much at this moment. A lot of people like big projected ones to get real peripheral. Why I don't like it is because there's a lot of other stuff to stimulate suppression and other things, because they see the room, they see the projector, they see the screen, they see everything. Here, they're literally, when I say their nose is on it, I mean they are here. I mean on it. On it in quotes, a centimeter off it. So that Coit's is very, very, very peripheral. I mean, it's here. Okay? These are the instructions. There's some letters in the middle. They're going to be blurry. They may be blurry. I don't want you to try to make them clear. I don't want you to look at them. I just want you to look through them. Ignore them. I am going to be moving something. I want you to tell me if the rope changes in any way at all. Okay? For very young kids, or sometimes I have to do this. I want you to look at the size and tell me if the size ever gets bigger and smaller. I find with my strabismics, almost 100% of the time, they can't give me size and distance changes simultaneously. They give me one or the other. They don't say smaller, closer. They'll do closer, further, or they'll do bigger, smaller, but they don't do both simultaneously in the beginning of therapy, or also for this test. Okay. So let's say even it's a young child, because sometimes you say, does it ever change? Kids might think it's going to change into an elephant. You know what I mean? You don't know what they're thinking of change means. They're not thinking. So I'll say size, and I don't care, because if they give me consistent size, and sometimes what I do also, if I think they're cheating in any way at all, I just cover up the little space on the bottom so they can't see whether it's numbers or letters. I just put a little piece of paper there so they don't know whether I'm doing numbers or letters. And if they're consistent every time, and I go back to 0, and this is exactly the way I do it. So now they're here. Tell me if the size ever changes. Or tell me if it gets bigger or smaller. 1, 2, 3, 2, 1, 0. Does everybody understand what I mean when I say 3, 2, 1? Okay. A, B, C, B, A, 0, 1, 2, 3, 2, 1, 0. And what I think I'm doing in my mind is I am massaging the stereo centers in the brain. Or stimulating. I like to use the word massage. So I'm just doing 3 bass out to 3 bass in slowly. To 3 bass out slowly, to 3 bass in slowly. Everybody with me? Number 3. Just slowly 1, 2, 3, 2, 1, 0, A, B, C, C, B, A. Okay? Back and forth. Sometimes it's immediate. Sometimes it takes 2, 3 minutes for it. I know this is boring. Just keep looking. Just keep looking through the middle. Just keep looking through the middle. Just keep looking through the middle. Just sort of daydream like you're looking across a lake. Just relax. And I would say in about 90% of my patients, my strabismic patients, I will get, it's getting bigger. It's getting smaller. It's getting bigger. It's getting smaller, and it's corresponding to bass out and bass in the correct way. And to make sure is, I don't always then, if they start giving me that, I'll go to 0 and do bass out again, 0 and do bass out again. So they say smaller, smaller, smaller. Not just bigger, smaller every time, because sometimes they watch your fingers move. So I want to be convinced that they're really getting it. If I can get that stereo peripheral fusion response, my prognosis goes up tremendously. And that's about 90%. Maybe 95%. Thank you. What I find is when I only use the quoits, they don't have anything to compare them to. So when they have these rings, they have a reference point. And it's the same thing. I say, now, okay, tell me if it ever looks like the rope is in front or behind the rings. It's behind. Now it's in front. Now it's behind. Now it's in front. And it's much easier to do distance changes when you have a reference point. You could put a penny there, absolutely. You could. You could put a dot in the middle. Or a penny. There's nothing magical about the other one. I just use it and I have it, and it seems to work well for me. And it's closer in size to the other one. So instead of having a dot, I'd probably have a ring. But yeah, if you wanted to take a piece of plastic and save the money and just put a black ring on it, it would work just as well. Okay, just a point of reference. I don't care if they're centrally suppressing. Oh, matter of fact, I just did this in a seminar 3 weeks ago in Italy. This is the responses. I want you to look, relax. The letters aren't clear. Don't look at the letters. Esotrope. Don't look at the letters. I don't care if they're clear or not. Okay, so just as the ring moving. Okay. Line 6 is gone. I understand line 6 is gone. Try to just look at the ring. Just concentrate. Relax your eyes. Relax your eyes. And again, it was like, but, I mean, you know, there's a little bit of dust on it. Yeah, I know there's some dust on it. It's not so clean. But it was like, okay. But seriously, I just want them to be peripheral, and then you get this large, large peripheral target. And if I can get peripheral fusion, I know it's possible. And then I want to use that to my advantage, which I'll talk about when I get into therapy. So I call that my massage technique. Again, sometimes I get it very quickly. 30 seconds, it's there. Other times, 5 minutes. And when I say 5 minutes, I mean a full 5 boring minutes. And I tell this 4-year-old kid, it's boring. But just keep relaxing and looking. Just keep relaxing and looking. And maybe the size is going to change. Really, really, really. You know, it's going to be sort of like magic. If the size can get bigger and smaller, bigger and smaller. And again, if that corresponds to numbers and letters, numbers and letters, numbers and letters, every time I do it, even 3 in one direction, I know they have peripheral stereo. It's not a guess. Yeah. Break. Okay, good. Perfect time for a break. 10:30. I hope that was interesting to people. 10:30. We're doing good. We'll finish therapy.